Hey y'all, happy Baby Friday. I am pleased that y'all are joining me for another healthcare happenings where I am really excited to have my good friend along with me today, Ms. Beth Schleeper of Advanced Coding Services. Hey Beth.
Hey, Betty, I'm so excited to be here, you guys. It's so fun.
It's good to see you again. I'm so good when we can, since we're apart, at
Yes,
least the virtual seeing each other is like exciting. So it's not always on the phone. So it's nice to
right.
like get to see somebody.
Put eyes on each other.
So I know. So, thanks everybody as you're coming in. Just go ahead and give us a shout out. Let us know you're here. And we are going to be talking today because Beth is one of my RCM queens. So we're going to be talking about denials management. Beth, for those of y'all that don't know her, is the owner of Advanced Coding Services. And she has been in the field and doing coding, auditing. She also, on her site with Advanced Coding Services, does the certification. I was like, I can't think of the word. Does the certification courses and webinars and things like that. And she also has some in-person retreats, which we'll talk about at the end of our time today. So you can find out where all of her retreats are going to be and what they entail. And y'all, I tell you, and I'll say this again when we talk about it at the end, but the retreats, the concept for these things is just innovative and a fantastic concept, Beth. I really think you hit the nail on the head with these. So for those of y'all who are looking for some in-person education with healthcare leaders and professionals, and it being in a more relaxed atmosphere where it's not real stuffy, and you can kind of eat with the speakers and really get some good one-on-one time and talk with everybody. This is a really good way to do it. And so when we talk about it at the end and I show you where she's going to be and where she's having them, I encourage everybody to go to Advanced Coding Services and check them out, because they're just really a great thing. So I really enjoyed presenting at one of them and being there with the attendees and stuff. Everybody has a good time. And it's fun when you're going to a conference and people are sitting there in flip-flops and maxi dresses, and we're playing games and all kind of stuff like that. So so check those out. But we'll show you where she's coming and get a little more detail from Beth at the end of the presentation. But other than that, she also had a company with her father, was a TNT consulting firm. So she's kind of moved through and done a few different things in the field. And she started working, front desk, right, Beth? You were
Right.
like front desk reception kind of thing, and moved through the
Moved up.
ranks like a lot of us old timers. And I know you don't take offense to that. So, I'm definitely in that rank there, old timers,
Yes.
and how we kind of came up through the field back then. Because when we first started, I'm over 35 years, so when I first started, they didn't even have names for coder. I mean, there wasn't a coder, it wasn't a position. You just kind of did what you had to do. And everybody, got, I'm just checking on LinkedIn, and it wasn't running. So everybody just did what they had to do in the office. And, people were doing back office stuff at one point, and then it was just kind of like, hey, you can do this, and you just kind of got shoved into coding. But it was exciting, back then. It was fun. And we all kind of like learned together how offices and practices should run.
Right.
And moving through things was a lot easier back then, I think, than it is for some of the newcomers into the field today, because it is now a well-known profession. And it's something that people, I mean, if you look at all of, the CPCAs, for example, every time, I mean, it's just getting more and more people coming in and wanting to get into the field. with us. So it, it is getting a little bit harder to do it that way.
Right.
But that was, that was fun back in those days. All the things, when I was talking with Sonal yesterday and Sonal Patel, we were talking about Stark and anti-kickback and all those, I
Oh,
was like,
right.
oh, I remember being in the offices when that didn't exist and how much,
Right.
much fun we used to have and stuff people would bring us and the
Yeah.
baskets at Christmas and, like all that stuff
Okay.
that we just, can't do anymore now because of federal regulations. But yeah, it was a different time, but,
Yes.
it's good getting in now too. It's still a good profession. But we need to have a little bit more education behind us, I think. So the people coming in new,
Right.
I think that's important. And Beth has also been involved in her local chapters with AAPC in Arizona, right? Is where you
Phoenix,
were
yes.
on
Yep.
with your chapters, right, in Phoenix. So so that's a little bit on Beth. And we have some people that are saying hey to us here. So we have a LinkedIn user. And again, I'm guessing that that's Sonal because every time I see on my thing LinkedIn user, usually it's Sonal. So Sonal, if that's you, give me another message that says yes, it's me. Plus she put the little emoji with the sunglasses. So
Very nice.
Jeanette Hayes is here with us today. So hey, Jeanette, hope everything is going well with you and you're having a good day. So, okay, denials management.
Yes.
What made you like spark on, and that denials management kind of like hit you as like this is the piece that I want to kind of dig into in a practice?
Probably out of necessity. When you so I own a third party billing service, and when my providers are like, hey Beth, I can't get paid, my cash flow has stopped, what is the problem? You have to start digging in and finding where the problem is and then fixing it. And so for me, it's out of necessity, but it's also fun because you're finding that needle in the haystack. Like, I love auditing because I'm looking at the big picture, and I'm finding the needle. Denial management is kind of the same. Like, we have to find what the problem is and fix it. And then when you see those EOBs start coming in, it's validating that we found the problem and we fixed it correctly. And now my providers are getting paid. So it just kind of was out of necessity. How do we fix this problem and move forward? And really the intent is you find out what the problem is, you fix it, but then you have to educate so that we don't have this to continue to be a problem.
Yeah.
It's fixing it, but then how do we, you know, you stop putting out fires and you start preventing fires.
Yeah, and I find that that's really like when I audit, it's kind of the same thing. I've been in practices where I will do an audit and then I'm meeting with the physician afterward and we're talking about, some of the things that they did that, where they need to improve certain things
Right.
or where certain things are miscoded,
Right.
in practices where they code their own things and maybe they're misusing modifier 59 or something like that. So I'm giving them some education and then I hear from them, no, well, you get I've always done that.
That's right.
Okay, we've all heard that 8 billion times, right? And
Yep.
so I'm like, okay. And I said, and then they follow it up with, well, nobody's ever said anything to me before, right? So then I'll go back to the practice and I'll say, well, in my conversation, with Dr. Gary, he told me that, we were going through some of the issues that he had and how he could improve and what was wrong with them. And he said that, y'all have never come to him and said that this is an issue. And, many times I would get the answer that, yeah, well, we just fix them on the back end and then keep. And I said, okay. I said, well, how many times do you do that?
Right.
And think of all the providers, all the other physicians and APPs you're doing that. Do you do the same thing for all of them? Yeah, it's just easier and faster. I said, okay, well, let's dig into that just a little bit here. How many times a day do you spend doing that and how much time are you doing that versus telling them once, you need to change and do this instead. They're never going to change their habits if you never tell them what they're
Right.
doing is not correct.
Right. If they don't know it's wrong, they can't
That
fix it.
whole flow. Exactly. So I get that a lot. And so I think with denials management, it's kind of like the same thing. You get to play detective and figure it out, but then you have to follow it up with that educational side of it, or else they're going to continue to make that same mistake over and over. And you're going to keep reworking the same denials over and over and over. And nobody's got that kind of time to waste in a practice anymore.
Exactly. And the reality is that so many of these denials are preventable. If we did our due diligence on the front end, when the patient called, people are like, oh, the billing starts when the claim drops. That's absolutely not correct. The billing starts when that patient calls and makes their appointment, and we get that information from the patient when they present, and then we make sure we have the correct demographics, get copies of their license and their insurance cards. Have we verified their benefits and eligibility? Yes, they're eligible with Blue Cross, but are we contracted with Blue Cross? Are we a provider? It's doing all of that due diligence on the front side before we ever see that patient, to make sure that our providers are getting paid what they're entitled to. But
yeah, and it's about getting it paid the first time.
correct.
The longer you wait for your money, the less your money is worth.
Absolutely.
So, we have to get them in, get them right, and get it paid correctly the first time. So that's really the goal. But of course, it doesn't always happen, for sometimes not even reasons that are under our control. Sometimes
Absolutely.
it's something on the payor side where they just didn't like something went wrong with their software one day, or
or the clearinghouse got hacked. Change healthcare.
Yeah. I'm gonna ask you about that one. So they're just, sometimes it's not anything that y'all could have sent the claim correctly. Everything's correct on it, and there's just something on the payor side where they took umbrage with what you sent them, and they're sending it back for some reason. But for the most part, sending clean claims, that's the goal every time, to get everything out as clean as possible to get it back in. And I see Jeanette is verifying, what we're saying, that verifying eligibility prior to scheduling, that's one of the keys. Yeah. And I think some of that front desk stuff, that front office work, gets lost in practices sometimes. I think sometimes it's because they don't have properly trained people in front office, to where they think they're just answering phones and scheduling appointments.
Right.
And that's where so there's a lot of pre-appointment work that goes on. So when you look at claim denials these days, with what you're seeing with your clients, what are some of the main denial reasons that you're seeing these days?
We're going to go back to, it's still the patient wasn't eligible on date of service, or Blue Cross. I love Blue Cross, but Blue Cross, you have to send it to your local Blue Cross, and that's great. But if my Arizona Blue Cross doesn't connect to Michigan, who says this patient is eligible or not, you have so many pieces in Blue Cross that sometimes it takes a long time to get that claim paid for a Blue Cross patient, because we're in Arizona, we have a Blue Cross of Arizona, but the patient might have Blue Cross of Washington. And so it's a process to do that. Sorry.
That's okay.
I thought I silenced all my phones. And so it's still, the patient isn't eligible, or we rendered a service that we weren't contracted for. Reminding your providers of their scope of practice. Yes, you might know how to do that, but you're not contracted to do those services. So that's not a payable event for you. I'm sorry, my friend. Yes, you might know how to do allergy testing, but you're not an allergist, and that's not your contract. So we're still, most of our denials are still in those buckets of, I don't want to say easy fixes, but kind of easy fixes. Patient wasn't eligible, or we're rendering services that are outside of the scope of their practice.
Okay. Now, with the introduction, and y'all please, I see that everybody's making comments and saying hey as they're coming in, and thank you so much for verifying that was you. So and hey to Jacob and Christy too, thanks for joining us. With AI and technology and those kind of things, I mean, back again, not to keep aging ourselves and like, well, back when I was a kid, but back in the day when we used to do these, I mean, when I first started in, we were still doing them on the typewriters, the
Yes,
1500s,
yes, me too.
and that was back when it was called the HICFA 1500,
Yes,
not the
that's right.
CMS
That's right.
1500. So for those of y'all that are listening in that are newer, yeah, we used to have to do all those claims on typewriters and type the claims up, and you used to have to hand sign the claim forms. They wouldn't take a stamp.
That's
So
right.
you had to hand sign them
Hand sign
all before you sent them in. So the whole claims processing thing was just hellacious back then. But we moved into electronic health records, electronic claim submission, clearinghouses, all that kind of stuff. And now we're at a point where everybody's going nuts about AI, right? And you see that some of the payors are using AI stuff with their adjudications, and they're picking systems and stuff about that. Have you at Advanced Coding Systems, are y'all utilizing AI, or what ways do you know of, or have you seen, that AI is being used in denials management?
No, I'm not doing AI because I do all of my own. Now, do we have form letters? Because I'm not going to reinvent the wheel every time, because you figure out your recurring denial codes, and then you have your letters, or your appeal process, and you go through those steps. I'm not using AI because, going back to what you said, I don't know about you, but when I first started, we were on the typewriter, and then oh, we're going to start doing everything on a software. Well, that's going to eliminate the human element. Oh, we're going to do everything electronically, so it will be a paperless office. Everybody says they're paperless. The reality is we're not. I mean, we're less paper, but we're not paperless.
That's very good.
It's less, but we're not paperless. But they always say, oh, it's going to replace the person. It's going to replace the person. The reality is that even if we use AI and they can write our appeals letters, that's great. But once you have that letter, you don't need to redo the wheel. And I don't see AI replacing us, because you still need that human element to figure out what the problem was. AI can write a paragraph, or they can write a blog and that kind of stuff, but they don't know how to process or how to think through the problem to get a solution. So
yeah, I think that's a good point with the AI stuff. I know that, like, sometimes I will use AI if I'm trying to think of like a cute name for something, or
right.
like an idea for what to do, and I'll say, I'm doing this. Give me some examples of some cute names for whatever. And so it'll spit me some things out, or I'm going to give a talk on something, and I'll say, what would you say are some of the important points to hit, and I kind of look at what I've done to see if, like, did I miss something? I kind of use it kind of to check myself, but to use it, and I hadn't thought of this until you said what you said, to use it for denials management letters, I think it would be kind of tough, because AI is kind of generalizing, like, it doesn't know the specifics. So you could have your form letter, and the specifics of that case you need to add yourself.
Absolutely.
So even if you used AI to make a form letter, you still would have to add the specifics yourself to that form letter. So if you already have the form letters, then you probably don't need the AI.
Right.
So yeah.
But going back to what you said, like, people are like, oh, AI and all the billers and coders are going to be eliminated. We can't be, because who is going to fill in the specifics of that form letter? AI isn't going to know that. Are we going to suddenly get, and maybe in a couple years, or 10, 20 years, we'll get somebody who says, hey, I know how to fill in that form letter using AI. That's fine. But right now, as it sits, we still have a job. Like there's still a human element that is required for billing and claims processing. It's just, we're still here.
Yeah. Yeah,
We're
I
still
don't think any of us with AI, for anybody that worries about that, I just like when computer assisted coding first came out, remember
right.
that years ago,
Yes.
and everybody was like freaking out about it's going to replace all the coders out there, and it's gonna, no, it didn't, because somebody still needs to check it for one, and for
Someone still needs to
two.
put the right code.
Exactly. I think that you look at any EHR that has the E&M thing in there, what will tell you what your E&M was, those things are not accurate.
No, no.
Not all the time.
Mm-mm.
There's some of them that are pretty good, but it can't put in the physician and APP's like thought process
Right.
of, do they, does that meet the criteria of a 4? Yes. But was it really a 4 from a medical necessity standpoint?
Right.
No. I mean, that stuff can't figure that stuff out. It does it by the algorithm that it has. And that's what you lose with the computer versus a person.
That's right.
Is that, yes, here's what the algorithm says, but,
But
the system's not going to but itself.
right.
It's going to give you the answer.
Right. Because it's looking at your checked boxes, right? And so it's like, oh, you did this and you did this. So it's like you're ticking off the boxes, but it doesn't have the provider's thought process, which is what you need when you're doing your medical decision making. It's decision making. Your AI and algorithm cannot do your decision making. So does it have a place? Can it guide you? Maybe, but it should not ever be your final code set or code selection.
And I see that Sonal has added in a nice little notice here. I did not know this, that today is National Medical Billers Day.
It is. Yes, just American Medical Billing Association. I am a member of AMBA, and they sent out a whole email this morning that, hey, it's National Billers Day. Okay, National Medical
Well,
Billers Day.
congrats.
Happy day. It's
Yeah.
our day.
Yeah, there you go. Y'all definitely deserve a day. So now with claims denials, I always tell people, when you look at a practice and you look at what's going on in the practice, obviously we need practitioners or else we can't have a practice, right? They have to be doing the things,
Right.
but the financial health of the practice,
Oh.
that is really dependent on the coders and the billers.
That's right.
Because you can have a practice that has a bunch of surgeons in it, and the surgeons could be doing surgery all day long, every day, 7 days a week, to where they're racking up millions of dollars in charges, on a quarterly basis. But if the billing and the coding isn't correct going out, they're not going to have money, or they're going to have less money than they should have. So that's really where you've got the financial health of the practice to look at, is in the coders and the billers that are in the practice, or help the practice if they outsource, to places like you for the billing services. So what would you say, or how big do you continue to see the financial impact on claims denials in a practice?
It's significant, because if I don't, and I'm saying me, but if I don't get the bill out clean and the money come right back in, my providers are not getting paid. And I think that as a biller, our mindset should be that, yes, I'm an employee or whatever your role is, but if you're not doing your job correctly, your provider isn't getting paid, which means you don't get paid. And so you can't have that mindset of, I'm just an employee, I punch the clock, I do my job and I leave. I mean, that might be your mindset, that might be your attitude, but while you're there on the clock, you have to remember that your provider and the staff and your practice, they're all dependent on you doing your job correctly to make sure they get their paycheck and can feed their family and pay their mortgages. That's a lot of weight on my shoulders as a biller, but that's the reality. Is if I'm not doing my job correctly, my provider's not getting paid and can't feed his family. And maybe that's too simple. Maybe me internalizing, but that's my thought process is I have to do this correctly, get my claims paid the first time or work the denials or rejections. So my provider is getting the money he has earned so that he can in turn pay me.
Yeah, and that's, when I see or hear professional coders and billers say, well, I'm just the coder, or I'm just
Right.
the biller. When I hear that
Just.
please y'all quit saying that. You're not just, first of all, nobody's just anything. But the positions in the healthcare field for medical coding and medical billing, that's where the money depends on for those
Right.
practices and organizations. So what y'all do is a critical job in the healthcare circle.
Right.
Without it being done properly, practices and organizations, they can't survive, they can't flourish, they can't offer new services for patients because they don't have the funds to do it.
Yes.
So what y'all do is super important. So don't ever do the I'm just a coder, I'm just a whatever. Your positions are very critical to a practice. So we love all of our medical coders and medical billers out there, and we're very necessary in the chain. So and Jeanette is 100% agreeing with all the things that we're saying here. So I love Jeanette. So and then Sonal made a comment here about just, and that word, as I was saying, just is not appropriate. Coding and billing professionals are integral to the financial health of a practice. So yeah, take real pride. You should be very proud of the positions that you hold in the healthcare field. They're very important.
I would say on the flip side of that, Betty, that as important as my role is, and as I reflect, as I look on that, I have to do this so my provider gets paid. The provider has to respect our role as well. And I say this with love and caution that we're worth our money, because if you're not paying us, you're not getting paid. And I'm sorry, yes, you can get somebody cheaper, but who probably doesn't have the right education or the right mindset. Could you have your son, your daughter, your wife, your mother, your brother? Yes, but are they educated and know how to work your claims? It is not simply enter your claims and push the submit button. That's the easy part. We all could do that. But how are you posting those payments? How are you tracking your money? How are you working your denials? Are you working your rejections? How is that all working? That's the other side of it. So yes, we are not just billers. We have to be respected on both sides. We have to respect ourselves and our role, but our providers need to remember that as well.
It's a great point, Beth. I've been in some offices when I used to work in practices, and I was in some practices that I managed where, it was the whole family kind of atmosphere and feeling, and there was that mutual respect for everybody. So that's always a great atmosphere to be working in. And I've been in a few where, it hasn't. And it can get a little rough. So yes, it's true. We all need to respect what each other's strengths are and what we're doing for it and bringing to the table. Now, Sonal a little bit earlier had a question to see, and I'm not sure if you've seen any of this as far as denials, but telehealth. Have you seen a lot of telehealth denials and with your groups of clients?
So I don't know if this is going to answer the question, but is it you have to know your payer, and you have to know what their guidelines are. You have to know what modifiers do they want you to use, and what place of service are they requiring you to use to get those paid. You also have to go back to your documentation. Is this really a telemedicine visit, or is it simply a phone call? Who has instigated the call? Did the provider call the patient to check in on them? That's not a billable event. If it's a phone call because it's a Medicare patient who doesn't have internet or a smartphone, so we're doing it via phone, then you have to have your documentation to support what it was. If it was a phone call because the patient needed a quick answer. So it really wasn't a telemedicine visit. I'm not sure I'm answering that correctly, but you need to know what service was rendered to know whether this was a true denial or we're not going to pay that because that's not the service you really provided. So I go back.
I have a client. Oh, sorry.
No, go ahead.
I was going to say, I do have a client right now that is getting some of their claims looked at. And a couple of them that I looked at were actually for telemedicine visits. So they had they pulled them because they had the modifier 95 on them that, is designating it was a telehealth visit. And when I looked at the record, it looked like a regular office visit.
Right.
And so in it, when I was going through, in one of the notes in the exam, there was a comment that said, exam limited due to telemedicine,
Right.
But that was the only place you saw it. And in the other notes, it didn't even mention that. And so I'm like, well, I said, first of all, y'all aren't saying that it's a
Right.
telemedicine visit in the note at the top of the note. You're not saying that you did a HIPAA compliant AV, that it was, synchronous, and, all of they didn't put the necessities into the visit. You could tell they did a visit,
right.
But it didn't meet the criteria for telemedicine.
Right.
And I think from what I've seen in auditing and getting calls from clients saying a payer wants these records and they're the telehealth visit records, that's what I've seen as the problem when they're getting the denials, is that they're not following the criteria. Like you're saying, it's even ones that did meet it, they're not putting it into the note to where it's supporting the fact that it is a telemedicine visit. So for me, at least, that's the part that I'm seeing. And, from a denial standpoint, depending on what the policy of the payor is, if it's in there that has to be stated and you didn't state it, well, there's really not much you can do about that.
No. Well, that's, if we don't follow the guidelines, we can, if we don't do our part and be compliant on our side, we cannot expect the payer to be compliant on their side. If we don't follow the rules, they don't have to pay us. And that's sad, but I mean, that's just the reality. I mean, yes, we rendered the care, but we didn't do the right documentation. So we're not entitled to payment.
Yeah, that always stinks. There's nothing worse for me as an auditor, as a consultant, as, I've worked with some of the best physicians on this earth. I really have in my career. I've been so lucky. And ones that would just do things that when you would sit there and watch, it would just make you cry from, how appreciative and how good these people are. Nice. And so when I'm with people like that and I look, and it's like, it just kills me when I'm like, you did it, but, and then they're losing out, there's nothing worse than that. So it's really important to have trusted people that are doing these things, to have either a good professional medical biller in your practice, or to have a good outsourced company that you use. Outsourcing, I'm not saying outsourcing, there's nothing wrong with outsourcing. No. It's great. It's a way for smaller practices to keep their overhead down, to where they don't have to pay for a full-time employee or pay benefits and pay, that's why we need all these outsourced companies. And why me, as a consultant, I mean, people couldn't have me sitting in their office all day trying to find things. I mean, it just doesn't make sense, but it's picking the right one that is the important thing. It's not like they look nice. Here, we'll have them come in, or hey,
that's a great picture.
Yeah. So just when you're looking for outsourced billing companies, billing services, look at places, like Beth's company, like Pam Vanderbilt's company, ones that are reputable, and that, you can meet with them and ask them for other clients that they have that may be willing to talk with them, and give them some recommendations of how they did it. Don't just pick somebody because they're the cheapest or they're the whatever, you have to do your due diligence, because again, it's your finances.
Absolutely.
This company is holding your money.
Well, and those those billing services that are cheap are typically cheaper because they've outsourced. They have outsourced your outsourcing. And most of the time it's offshore. Everything that we do here at T&T Consulting is completely in my office. I mean, I have 2 remote billers. One is in Texas, one is in California. That's as remote as we get. Everything else is here in Phoenix because I'm kind of a control freak. I'm not really a control freak, but I need to put my eyes on it because whatever goes out the door has my name on it. And it's important to me that I maintain my reputation, that we do what we're supposed to do and that we're getting the money out for the provider. And, we're talking about the telemedicine. That's what we do. We have to educate our staff here and myself of what is happening, making sure that we are looking at payer guidelines and their updates and their newsletters to make sure that we are in compliance with how are we billing out telemedicine or how are we doing this and that, to make sure that our providers are getting the service from us that they have requested.
Yeah. So to that, the denials management issue, what are in your company, what is your kind of practice or your steps when you're working, your denials management? Like what strategies do you employ? Do you have specific people do specific tasks or specific days for specific payors, or, do you have like a game plan laid out for them?
So at the beginning of the week, we do all of our billing, and then about Wednesday-ish, we kind of shift to, okay, now we need to do the payment posting. And I just kind of jump in and do a lot of everything. I have girls who are assigned certain clients and they do that. But then I jump in and post payments and I look at these and I start seeing those things. I'm very hands-on to make sure that we're getting everything correct. And so we just kind of, hey, here's an EOB. Did we check this? Hey, we need to look at this denial. We might need to request this record. How do we code this? Let's look to make sure our policy was correct. Did we bill according to the policy? So it's kind of a group effort. And I'm a very visual, and we document it electronically, but then I will have a file that I can see because I have to.
I love you, Beth. That's me. Someone and I talk about that all the time. We're doing things and I'm like, see, I have the paper here. Someone's looking at it on the computer and I'm like, here's the paper.
I have to have a drawer. Like I have to have my what my notes. Yes, I have it on electronically so anybody can see what I've done. We have a share file.
Yes.
But I have to see it because for me, and it sounds horrible, maybe I'm just old, but out of sight, out of mind. And so if I don't see it,
no, I'm with you.
It's all good. But that's not the reality. If I don't see it, that doesn't mean it's all good. It just means it's hidden.
Yeah, Christy says she has to do the same. So we're not the only ones. Now, because I get this question a lot from people, and I often wonder it myself anymore. Back in the day when I was in practices, as my main, thing, if it was any sizable practice, the decision had to be made. How do we want to bill? How do we want to code? Meaning, do we go by Medicare, or are we going to go by Medicare for Medicare and by CPT for everybody else? Or are we going to look at the payor, because some payors may accept something that other payors may not. And, but now there's so many, and there's so many different plans and so many IPAs and IPOs, and this one's paying for that one. And as a billing, when you do the billing side of it, how do y'all keep that stuff straight? Like, oh, well, it's Medicare, and so they'll accept it this way. Or now that we have all these Medicare Part C things where, they've got some additional services that maybe they pay for that traditional Medicare doesn't pay for. Right. So, how do y'all keep that kind of stuff straight?
So if there are Medicare patients, they're billed based on Medicare. Everybody else is based on AMA, the American Medical Association, our CPT, unless we have specific guidance from a payer that says we want RT and LT, not 50. Then that's fine. I mean, we kind of keep a spreadsheet. We keep our little notes in OneNote about.
That's what I was getting at.
Yes, about what is allowed and what is not. And so, again, it's a OneNote and it's in the share file. Everybody can see what what the guidelines are, and it's based on payer and specialty. My pediatrics, of course, Medicare doesn't apply to them, but we have to know, they're more Medicaid, so we have to know what those Medicaid rules are, as opposed to a family practice that's predominantly Medicare. So yes, we have to know the nuances for each of our practices and each of our payers within those practices.
Yeah, because otherwise, once again, you're going to start having denials that are coming in because of specific policy issues.
Right.
So being able to head that off on the front end, is important. Someone was asking an E&M thing about, again, denials. She's asking if you're seeing denials or down coding on level 4 or 5 E&M codes now that, since the 2021 guidelines came out. Are you seeing more scrutiny on the billing end of it when payers are coming back, on those 4s and 5s?
I'm going to say no, but yes. Yes, but no. I have seen a handful. If we bill out the patient has strep throat and we bill the 99214, yeah, I'm seeing those down coded. But then can we appeal those if our documentation is correct? Yes, because sometimes it might be a new patient. Sometimes it might be a geriatric patient who needs more time to understand how to take their antibiotics and really what a strep throat is. And so can we appeal those? We can. But just across the board, am I seeing those? I would say no. Any ones that I've seen are because typically just the diagnosis code alone doesn't necessarily support a 4 or 5.
And I think that's a great point, though, to put out there for people. So y'all, there could be, a strep throat patient that also has some underlying comorbid conditions.
Absolutely.
And that really makes it that moderate level, that level 4, because of these other factors that came in, and maybe the medications that they were able to give them had to change because of this underlying condition. And so if you're just reporting the strep throat ICD-10 code, the payor system is not going to know that. They're not going to know the patient also had this comorbid condition that, made all these adjustments necessary for the patient.
Go
ahead.
I was going to say, case in point, my husband has allergies, sinusitis, and asthma. And some of those steroids and some of the allergy medicine, the steroid affects his diabetes, and the allergy medicine has sugar. It also affects his diabetes. So when he's being seen for his allergies, sinusitis, and asthma, yes, we're a longer visit than normal, because then we have to talk about, okay, we might need to shift your meds a little. You might need to change how your diet is working for these 10 days that you're on these pills. And so, yes, a diagnosis of strep throat is fine, but does the patient have comorbidities which could support a level higher than what the payer thinks? Yes.
Yeah. So that's the thing you want to take away from here, to avoid these kinds of denials, that then you have to pull the record. You have to look at the record. You have to say, oh, well, the patient also has these comorbid conditions, and that was affecting, because the payor is not looking at the record. They're just looking at the claim you sent them with the CPT and the ICD-10 code on it. Right. So, then you have to pull it. You have to evaluate it. You have to ask sometimes the physician or APP about it. You have to write an appeal about it. You have, so you're having to go through all of this work to get that correctly paid. Whereas if you had put those correct ICD-10 codes on the claim, it might have just went right through, so I think back in the day, again, when I first started, Beth, now I don't know how many years you're in, but when I first started, we didn't have to have it was ICD-9 back then. We didn't even have to have them on the claim form. We could submit a claim form with just a CPT code on it, and we would get paid.
Okay. I started in 1996. So
okay. But I got you way beat. So, so yeah, we actually, because if we couldn't figure out the ICD-9 code, we would just send it without one, and it wasn't a requirement. Well, then they started requiring that you had to have an ICD-9 code. It was ICD-9 back then. You had to have an ICD-9 code on the claim form. So, ICD-9, ICD-10 diagnosis coding has kind of, I think, been like the lower rung thing that people don't think as much about. They
Right.
always think about CPT as driving the payment,
Right.
because the CPT code was telling them what you did and how much they should pay you.
Right.
So I
That's the
think
driver.
sometimes the diagnosis codes get ignored as not so important.
Mm-hmm.
But now, because of all this medical necessity things that are out there and that are talked about all the time, the thing that supports the CPT code that gets the payment are the diagnosis codes. So, just to use unspecified all the time because, it doesn't matter, there's a code on there. To just do the condition that the patient came in for and not put the comorbids because there's a code on there. That kind of stuff is not really doing your practice and your organization any favors and could warrant, more denials than what you should be getting.
Right.
So always make sure that you're paying attention to your diagnosis coding.
Well,
it is so much more important now than what it used to ever be. And so some of us old timers, we kind of just poo-poo diagnosis codes. We can't really do that anymore. That's going to be a cause of, a lot of appeal work that would be unnecessary if the stuff had been on there.
Well, and what I have noticed is you can get an unspecified code through a time or two. Yeah. And yes, it'll get paid. At some point, if you continue to bill with that unspecified code, at some point they're going to catch you. At some point, you have just made a bigger mess that you have to clean up because they're going to go back and recoup a year's worth of pay for a patient because you used the wrong code. And so it's important that, some of our, depending on pathology, maybe we have an unspecified code today right. because we don't have pathology. Right. But when we get pathology, my code better change and be much more specific than it was, a week ago. And so it's important to keep up with those diagnosis codes to change them as our patients come in, as their diseases or disorders or conditions progress or regress. Because at some point, you're going to have to work those denials if you don't.
Yep. And it's all about lessening that so that you can pay attention to the denials that really require that work, not the busy work denials, the ones that you really have to dig into. So, Jeanette finds it funny what I say. Yeah, Jeanette, we used to get we used to get away with a lot of stuff in the old days that we just can't do anymore. So, then she asked also a question though about your billers. Are your billers, do you have your people obtaining prior authorizations? Did they do that, or is that a process that the practice itself is responsible for?
That's in my world, that's a clinical thing. There's going to be questions that probably are going to be asked on that prior authorization that needs to be answered by a clinician, whether it's an MA, a nurse, whatever. That's outside of my scope. Once you have the prior auth, I can bill for that service. But
all right, and now I wanted to just ask you about the Change Healthcare thing. How did it affect, or did it affect any of your clients? Because I've heard that they're all good now. That everything's restored, and were you affected, and do you find that that's true? Those are my two questions.
Yes, I think everybody has been affected because Change Health is a clearinghouse, but it affected. It was a ripple effect. It wasn't just Change Healthcare because it affected payers and their connections to checking verifying benefits and eligibility.
And pharmacies and everything.
Yes. Yeah, we had a pharmacy here in Phoenix that couldn't check eligibility for anybody because the whole Change Healthcare was down. So has it affected us? It has, and we're moving in a very different direction, and we're fine here now. But I had a call with a provider 2 days ago, a brand new provider, and she's like, "We haven't gotten a check in 6 weeks." And I said, "Well, your old billing service probably was using Change Healthcare." And she's like, "Yes, but we're not getting a check." And I know that people were dropping claims to paper. That's not getting processed either because every system is set up or geared towards electronic, and so they're getting hundreds of thousands of claims on paper. They're not able to manage that. And so, it has been a whole ripple effect through the whole industry. And anybody, even if you're not using Change, you've been affected, whether you know it or not, you've been affected. And the last email I got from somebody at Change was that they are working on reintegrating, but that they were going to start with the big hospital systems and the big payers, and start reconnecting on those sides and the pharmacies. And then they were going to start working on the provider side of reconnecting us, because everybody who was connected has been disconnected.
Oh, I didn't know that.
So yes, that's what the email said, was everybody who was connected has now been disconnected. So there was no connection anymore. So now they have to restart your service, if you will. They have to reconnect and get service restarted.
Yeah, I guess they probably had to do that to protect them at that point, right? To just like, oh no, we're pulling the plug so that there's nothing else that can get out.
Right,
yeah, I hadn't thought of
if
that
they're
aspect.
infected and we're connected, it could trickle down into all of their clients or customers or everybody.
But did you personally, your billing company, did y'all use, or do y'all use Change, or do you go through and you did?
We did, and we're done with Change now. We have a whole brand new clearing. I'll tell you, when Optum bought out Change, because it was, I can't remember but way back in the day it was like MDon, and they've changed a couple times, and my gut said don't do this, but I didn't change then, because I didn't have a reason to, except my gut said don't do it. But I went along with it because all was working, and now it's not. So I kicked myself, but a lesson learned.
Yeah. Oh, good. I'm glad you got everybody going back in there. Now, what advice would you give, or do you give, to your practices and to anybody that's watching us or listening to us, on what they can do to improve the claims denial rate for a practice? Like, what can that practice do besides the front desk stuff of making sure you're checking cards? Are there other things that you would advise them to be checking on internally that would help out on that billing end of it, to where the claims denials weren't getting like so monstrous for somebody?
I know you said forget the front end, but that's really where it starts. You have to make sure your front end stuff is good. You have to make sure your documentation is good. And then you have to make sure that your coding is correct. Coding being your ICD-10, your CPT, your modifiers, your place of service. All of that is coding. We need to make sure all of these pieces, it's like a puzzle. All of these pieces fit together. And if they're not done correctly, we're putting together a puzzle that's never going to fit. And so you have to make sure all of those pieces are complete and that they're together and done correctly, so that we don't have that denial management problem that becomes a problem, so that we can make our you can have denial management because the patient wasn't eligible, because we had a wrong member ID number. Those are nuisances. Like, those, just forget it. That's ridiculous. If I'm going to have to work a denial, let me work a denial that's a real denial, because the patient had a new service, or because we had to use an unlisted code or something. That's a genuine denial. Make it worth my time and energy to do that. Just because we didn't verify the patient on the front end, that's just a nuisance. That's just spinning my wheels and wasting my time. And I say that with love.
No, yeah. And when I said forget the front thing, again, that wasn't it was like, we have discussed that. So it wasn't like just forget them. They're critical on
right.
But with Medicare, Medicaid, are there like specific, I know, like annual wellness visits, the IPPEs, those kind of, when you get things where they've been looking at like all the extra things. We were just talking about this the other day. I was talking about it with Sonal. When you have all those extra G codes that can be billed with it, that are separately reportable if they do it, but if they document it, so Medicaid and Medicare, have some different little tricky things, that they have that commercial payors don't have. So if you have a client that is heavy with Medicare and Medicaid patients, for your billing service, do you do special kind of instructions to them on, there are specific things with these patients you have to be mindful of to try to, again, be proactive, right? With managing those denials.
Right. And we call that education. It's a lot of work, but if I educate my providers and they listen, that is key. I can educate you all day, every day, but if you don't listen and internalize and make those changes, nothing I do is going to help you. But if you get the education and you make those changes, that's significantly going to help. You have to know what key pieces are allowed or required as part of your annual wellness visit. You're welcome to Medicare. How many times a year do you get to bill those? How many welcome to Medicare visits do you get? And so, yes, we have those kind of cheat sheets, if you will. We have those notes of so that it's important. And here's what I say. When we take on a new client, there's a conversation of what services do you provide, so that I can look at what services you're providing to make sure your documentation is correct. And to make sure your documentation is correct, meaning I need to know your thought process, not, did you check all the boxes so I can bill that for you? But did you do those services and then check the boxes? So this is a billable event. So that we are getting those paid, so that they're not denied. When we have a patient come in, it's a brand new Medicare patient, but they might not be a brand new Medicare patient, might be new to us, but they've had Medicare for 12 years. They don't get that G0438. They've had that. And so, are we paying attention to those things? When I have a practice that when they do, it's a brand new patient, so it's a G0438. Yeah, my friend, it's not. They're in their 80s. They've had their welcome to Medicare visit. This is not their first rodeo.
Yeah.
Asking them, have you had that visit? Maybe it's just the front desk asking those questions up front, so that we're not getting the denials on the back. So we're scrubbing those claims correctly and making sure we've done all of the pieces that are required to make sure we've done those. Yes.
Yeah.
That's very important.
That's great. We are coming to the end of our hour already, Beth.
Oh.
So before we say bye to everybody, I just wanted to give you some time to talk about these retreats that I alluded to at the beginning of the program, because these are the ones, y'all, that I was talking about, her Mastering the Business of Medicine retreats.
Yeah.
That she has in just a much different way than what you normally think of for a conference or a retreat getaway kind of thing for going to a coding conference. So Beth, what kind of information do you want to tell people about these? Because I think they're fabulous.
Thanks. So they're limited to 100 attendees because I want these to be small. Like you talked about earlier, Betty, I want these to be where we sit. All of the speakers are sitting with the attendees. If you want to have a conversation with Betty, you find what table she's sitting at. You sit at the table with her at breakfast, lunch, or supper, because we're eating meals together. We're all together for that weekend. So we have Georgia in April, and I'm really excited. Our pre-treat. So we have pre-treats because we used to do AAPC exams on the Friday, but we can't do that anymore. So now we do a pre-treat. So our pre-treat for Georgia is denial management, and that's with Christine Hall, Dawn Self, and Carlene Dietrich, and they're talking about working your denials and how to prevent them, kind of thing. So that's Georgia, and then we have Boston in June, which I'm super excited about. This is our first time there. We're going to be.
I'm sorry, I don't mean to interrupt you, but it's by the harbor.
It's by the harbor. That's right.
For those of you who get that, that's my Boston accent try there for y'all. Go ahead. Okay, go ahead.
We have some, we've had some very comical conversations about what to name some of these. Of course, we go with the safest, and it's by the harbor, and it's in Boston. It's at Eastern Nazarene College. So it's going to be kind of a college event environment. We're going to stay in the dorms on campus. We're going to eat in their dining hall. And so we're just kind of all going to be together. It's 8 minutes, I'm told, from Logan Airport. So fly into Boston, to Boston Logan Airport, get an Uber, get right on campus, and you'll stay. I'm told that Boston is the walking city of America, so you can walk anywhere in 15 minutes. So
Yeah.
you don't need to get a
Well,
car.
I've been there for some consulting work, and I definitely don't remember driving down in
No,
Boston. That was, oh yeah, I never again. I tell you. So yes.
kind of crazy. And then we have our business of medicine by the sea. That's in San Diego in August, and I'm really excited. This one's going to look a little different because instead of being on a campground at a retreat center, kind of in the woods, or at a college, a university, this one we're going to be in the Holiday Inn on the harbor in San Diego. So it's Holiday Inn Bayside. So we're on the Bayside. So it's going to look a little different. We're going to have the same education, but instead of, in a dorm setting, everybody, there's a link and everybody will book their own hotel rooms. If you want to stay in the hotel with us, you get a link and book your own room. If you want to stay somewhere else, or you're local and you want to commute, that's up to you. Phoenix is going to be the same way. The business of medicine is actually Retreat in the Pines is really going to be, we're going to rename that, because this year we're going to be in Phoenix instead of Prescott. And it's going to be at a hotel again, and you'll get the link and you'll book your own room. We're trying that to see if that makes a difference, because San Diego, the hotel has a shuttle right to the airport, and it's about a 6-minute shuttle from San Diego airport to the hotel. The Phoenix retreat is going to be probably a 6-minute retreat. I mean, a 6-minute shuttle from the airport. At the hotel, you can see, if you stand and look south, you can see the airport. So it's right there. But it's a really nice hotel. It's the Hilton. And then we'll wrap up this year with our retreat in the Big Apple, which is Hudson Valley, New York, which we're going to do that in October. And the intent is hopefully we'll see all the fall foliage, and that's on a huge lake in New York. So you kind of walk around the lake. It's great. It's quiet. It's peaceful. We did it last year and it was absolutely amazing. So
that sounds beautiful.
Yeah, all of them, they're amazing. And they were limited to 100 people. Each one of them has a pre-treat that's different than the others. Like the San Diego, the pre-treat is going to be about anatomy. And I'm hoping if I can talk to somebody on this call, Betty, to come out and maybe do a whole pre-treat on consulting. That's kind of a goal. And the one in Boston is all about, the pre-treat is about leadership and being the leader you are meant to be. I have a pastor who speaks at all of the ones here in Phoenix. He's coming. We have Robert Kiesacker, who's done a great job on
leadership. He's great.
He's absolutely amazing. Carlene Dietrich is going to do a presentation on being the leader you were meant to be. And that's absolutely amazing. It's kind of a interactive piece for her. So we have great pre-treats that are going. So I'm excited we're developing, and I'm excited to see who all is going to show up. But remember, it's limited to 100 people so that we keep it small. So it's important to get registered quick.
Yeah, so y'all make sure you go check it out. Now, Beth's site for advanced coding services, you can find her on at advancedcodingservices.com. Yes. And if y'all aren't connected with Beth or follow Beth on LinkedIn, you can find her here at this link you see on the screen for LinkedIn, or you could just search her name, Beth Schleeper. That's a hard one. So you can connect with her on LinkedIn too, and look for her posts that'll have stuff from Advanced Coding Services on it. So that's things that you should check out. So thank you, my friend, for coming on with me today. This is a lot of fun having you on. And I was glad that you could join me today and we could talk about denials management a little bit more. It's always fun to see you and to catch up. And again, people, make sure y'all are going to check out Advanced Coding Services, check out the retreat, connect with Beth. Anything that you want to say in closing to the attendees or the listeners today?
I think I would just say I hope everybody has a great Easter weekend. It's going to be, I I hope it's beautiful weather here. We're 71 in Phoenix. It's kind of been weird weather, but I hope everybody has a great Easter weekend, and I hope to see you at the retreats.
Wonderful. Yep. Yeah. Y'all all have a wonderful Easter. Happy Good Friday tomorrow. Today's Holy Thursday. So,
Yes.
I hope everybody can enjoy spending some time with their families and things like that this weekend, and look forward to having the program back on in another couple weeks. Of course, we have our next session, and I'll be happy to have y'all join me again to see what's happening in healthcare. So until then, y'all have a good afternoon, good weekend, all of that good kind of stuff. And we shall see y'all soon. Thanks.
Thanks. Have a good one.